Good afternoon. Today we have a very exciting topic. We are going to focus in our fourth webinar on quality management for tomorrow. And the way we are going to explore the notion of quality management for tomorrow by understanding the quantitative analysis of operation and quality, and then how those numbers and information leads to processes in one hospital, Glen Cove, where we have the CEO, Kerri Scanlon, who in a moment she'll introduce herself, she'll be talking about it. I have also with me my partner, Andrea Restifo, who is responsible for quality and operation at North Shore University Hospital, and she will provide her input in terms of outcome measurements in the format of CMS analytics. The exciting part of today's session is the fact that analytics and quality didn't change much, in spite of the fact that we have now, through computerized systems, we use heavy-duty statistics. However, in the 1800, Florence Nightingale, which is my guru in terms of quality, already addressed very complicated issues in statistics that helped us to understand better the dynamic of key variables in quality. And also her work led to change policy in the military, which is a very conservative organization, and also helped to change the opinion of members of parliament. Statistics. She changed, and I will illustrate it later on, she changed the data constantly to make it attractive and understandable to the people who make decisions. So since Florence Nightingale, very few thinkers in the field of quality really were able to influence policy on such a magnitude. So what CMS is doing is one of those organizations that helped us to shape the relationship between process and outcome in terms of the measurement that both Andrea and Kerri will be talking about it in great detail. I will interrupt them from time to time. But this is really exciting. The second thinker in quality that unfortunately didn't have an impact at the time on policy is Cadman. Dr. Cadman was able to illustrate through collecting information from a concurrent point of view on all patients who went for surgery and left the hospital either dead or alive, and also those who died later on at home. However, the physician at the time, especially the physician from Harvard, they objected to his analysis and didn't think that this type of analysis is really useful in terms of understanding medical care, which is absolutely fascinating. So the Joint Commission picked up on Cadman a few years, and they are using his philosophy in terms of developing guidelines, especially in terms of understanding quantitative analysis. So before we go, this is my brief introduction to the session. Hopefully it will be very dynamic like the other three. I would like to introduce Kerri Scanlon, who says something.
Thank you, Yosef. Thank you, Andrea. I'm Kerri Scanlon. I'm the executive director here at Glen Cove Hospital, which is one of the hospitals in Northwell Health. As executive director, I'm the hospital administrator for the facility. My background, I'm a registered nurse and nurse practitioner by training. I was the chief nursing officer prior at our quaternary academic facility, and prior to that, the chief nursing officer at one of our tertiary medical centers. But prior to that, I had the distinct honor and privilege to work with both Andrea and Dr. Dlugacz, and really worked in corporate quality for a number of years, about 6 years, and got to really go out to the facilities in our health system and to teach and really implement quality improvement science and methodology. I'm a cardiothoracic nurse by training, and I heavily look at really what I do today, strategically, operationally within the institution. I think the foundation in quality and quality improvement science is absolutely critical to today and where we need to be in the future.
Thank you very much. This is a beautiful introduction. And I want to make a point that ICU nurses, in particular, are very focused on quantitative data in terms of the patient.
Very much so.
So it's a natural evolution for you to move into this area. Andrea, Restifo.
Hey, thank you. And thank you to the American College of Medical Quality for having this lecture series, and in particular, this topic, quality management for tomorrow, because as we come out of COVID last year, we are really in a new environment, and we have to figure out how to make the programs that we have at our organization successful. I myself am a nurse also, have started in the ICU and had my career in ambulatory surgery, as well as in case management and utilization review, and then for about 25 years in quality management. I'm very, very grateful also for Yosef for really sharing the methodology with our colleagues, but also recently, Yosef and I are teaching at Hofstra, and we're really teaching in the business school quality management methodologies and how it applies to business models, and also giving ideas for future strategy. So I'm pleased to be here, and thank you very much.
Great. So with this brief introduction, as you can imagine, we'll have a wonderful time. The reason that we focused on quality management for tomorrow is that are there any changes that occurred during and even today as we contrasted with different situations during COVID? A lot of crisis management that is taking place. There are new variables that we didn't focus in the past. We're focusing now more. We're looking at human resources, how employees react to the COVID, what is the stress level and burnout, and then how does this all impact the care we deliver? And hopefully both of you will be able to make a comment on that later on. So this will be really exciting. So if you look at the first slide, what will be the objective today is that, again, looking about the impact of COVID on our understanding of quality management. And it's very interesting because CMS basically didn't change the data. So the variables are the same. The risk adjustment is the same. The benchmark is the same. So what really changes is the process, not the numbers. So the numbers are stable, and we can continue to work with those numbers, which shows a validation of the data that CMS produced in terms of the various measurements. Then we look at the scope of care and how this changed and had an impact on the process of quality. So, for example, we have new things today. like telecommunication, telemedicine. We are focusing on how patients come to the ED, how we deal and cope with death, and how we cope with the elderly and chronic diseases much more. So this is all we will talk about, hopefully in a brief summary as we talk about quality. And then what does it mean, how the executive looks at quality management? Is it only from a regulatory point of view? It's something that we have to do, or it's something that we need to use in order to improve? And you can imagine Kerri falls into the area where we need to improve. We use information to improve, so it's a much more dynamic type of process rather than simply respond to regulatory expectation and do what we are supposed to do. This is simply not enough. And then the other is that how do the clinical staff integrate quality in their daily function? This is not an easy process. They need to deal with so many different variables that occur. And then also at the same time, what does it mean under this type of pressure, quality? When people are very tired and they work long hours, how do you do that? How do you focus on a measurement? Because you really more look at what happens today in the present, in the interaction between the clinician and the patient, not in terms of an overall process. Hopefully we'll have an opportunity to talk about the quality structure and process. And then, of course, how do we implement accountability, not only in the organization itself, but in the community? And Kerri will illustrate it through an approach to geriatric population, which is becoming the most important or the biggest population in the United States, and then how this leads or reflects in the community in terms of accountability, because the patient is not passive in this situation. He needs to participate in the treatment. Very important, because the patient is the only one who really knows the symptoms. And the way they describe it, it's extremely important. So I'll continue with the next couple of slides. As I mentioned to you, I simply, since I created or worked on quality management, it's now 40 years. I always admired how Florence Nightingale was able to make change in the delivery of care, how she was able to reduce mortality. And what does it mean? And this is not an easy task. She did it under a military, she did it under military condition in terms of a battlefield. She did it under circumstances that were not easy, because people died in the hospital and outside the hospital. The healthcare was not organized like today. They didn't have databases like we have today, and they didn't have a computer. And regardless of all of those situations and obstacles, not only she created a database that even today, we need to understand it and share it. And in fact, I saw an article in the American Scientific Journal about Florence Nightingale. Somebody from Harvard wrote an article about it, and this is where I have some of the data from. Absolutely amazing what she did. She was able to shape the way we deliver care in a battlefield and in a hospital, and also how sanitary conditions have an impact on the patient in terms of the physiology and well-being, and also in terms of airflow. It's simply amazing that people really listen to her, and the way she made the impact is, if you look at the next slide, she presented data, and the data may look simple. It's a bar graph, and I'm not going to now dwell on the statistics of bar graphs, but what she tried to do, Florence Nightingale, is to show generals in the army who didn't believe her and people who members of the parliament to figure out what's happening. Well, there is an impact. So one of the first situation, what she discovered through observation, which is amazing. She did a lot of rounds in the field and also in the hospitals. And it's also my philosophy in quality that you need to do rounds constantly, not to sit in the office. And what she discovered that people who were wounded in the battlefield didn't develop infection, as opposed to people, so soldiers who went to a hospital, they developed infection, died. And this is really, it triggered in her the concept of starting to compare data. And it's simply amazing. As you can see, it's a very, very simplistic type of presentation. So she talked about the green is the population in general, or it's blue, I don't know. And the red is the soldiers. And you can see, regardless of age, you see she already used a 3-variable analysis. I'm talking about the 1800s.
Right, right.
When I went to learn statistics in the 1700s, in the 1970, we talked about 3-way variable. And here it is. Look how beautiful it is. Very simple. And she was able to convince them that regardless of age, so the concept that age is the most important variable in causing mortality, what she found that when you compare the general population to the soldiers, it washes out. Here, no regression. 3-way variable show consistently they are high. There's a slight movement, if you can see in the general populations, they get older, but statistically it's not significant. And this is the brilliant thing about her presentation. So you can imagine she presented this type of data to generals and to members of parliament. And they liked it. They simply liked it. The next slide, which is even more powerful, what she did is to look at causality, looked at cause and effect in terms of mortality. And I'm going to use the different pie charts to illustrate the impact of mortality. And what she figured out, once they did intervention, the mortality went down. So I don't want to elaborate. This is really not a class on Florence Nightingale, which is maybe I should do it one day. I would love to do it one day. But today we're only focusing on how she uses analytics. And what she found is that, again, that in the blue, the soldiers who died from wounds are much higher than regular patients. And also over time, since they put intervention in terms of sanitation in the hospitals and airflows, the level of mortality started to go down. Okay, so here it's a very simple story. I'm doing something, here it is, and here is the impact. What do you want to do about it? Okay? So the what to do about it is change policy. In the third analysis, she used a root cause. And it's really amazing in terms of explaining mortality rate. You have to remember that we always look at root cause of mortality. We do some fancy statistical analysis, and we don't always find it. And she really said that the data show that fixing the sewer system, having cleanliness in the room of the patient, washing hands, making sure there is airflow or ventilation is extremely important. And they bought it. They bought it, and the city, London, they started to fix the sewer system. If you can imagine, it's not an easy task. It takes a lot of money to make sure that the water is clean and so on. And then, of course, the hospitals, they had to rebuild them. So instead of having those huge wards, they made it smaller. They made sure there is space between one patient and another. They made sure that the rooms and the floors and the walls are clean. And the most important, that they can have sunshine and can have air. So it flows. It's not something that if it sticks in terms of the different bugs that we are facing today as patients come to our hospitals. And we're trying to figure out how to prevent infection. And it's a very complicated process. Even IHI tried to do that, and we developed different protocols, but nothing stands to what Florence did. Simply, I think it's unbelievable, and we need to imitate her work. It's not about complicated statistical analysis. It's really about understanding the relationship between the variables that we put in, let's say, in a regression model to explain mortality, and the clinical variables that are at the bedside. And this is what she did. She realized that sanitation is a key issue in terms of creating infection. And they developed a policy around it. What does it mean? So it's about the sewer system, it's about the water supply, about clean water, drinkable water, and so on. So this is simply, I think, an amazing process of looking at qualitative analysis and key clinical variables at the bedside. In the next...
So would you say she really invented the quality for tomorrow, and she put the value on patient safety and the outcomes associated with that? And really, as we need to do today, continue to work on the quality, safety, outcomes, data analysis, and look to see how that can continue to change policy.
Yes, and also to figure out how we can create a value. So she created a value based on the data. She said this data is so important, and the value is reduction in mortality among soldiers. And it was important for the parliament at the time because they cannot get so many soldiers. They need to keep them alive and not to die in the field or in the hospital, but cure them. So this was wonderful. We are not at this level where we can figure out how we can change a policy. I mean, excluding what CMS is doing now, which I believe is the right thing to do, and it's closest to Florence Nightingale's approach.
But it's interesting the things that she did at that time, which were groundbreaking, really, as you said. And to have them accepted, as you said, in a very, very parochial, era in government was just unbelievable. If you relate that to what you were speaking about with COVID, for example, when you really think about it, many of those interventions still remained just as valid today to prevent infection. and to prevent spread of infection. And I think sometimes when we look at the hospital environment, we don't always appreciate the infrastructure that's required to build to allow for those things to happen every day with our staff, to make it easier for them to comply with the things that we need to do to prevent infection.
You're absolutely right. I think that it's a beautiful example. I think what happens today and what happened in Florence Nightingale time is almost similar. And so it's a beautiful segue to what you are going to say about Glen Cove. So if we can go to the next slide, it's you.
Sure. Glen Cove, as I mentioned, is a hospital, a smaller community hospital. We have 247 hospital beds, but we operate on a daily census of around 150 beds. The concept is really not about so much what the hospital statistics are, but the concept of it's an institution that is really trying to meet the needs of the community. A community hospital that has centers of excellence and specialty, but also meeting the needs of the community. And we look at a number of things in that we're very proud to be part of Northwell Health and proud, that we're magnet designated, CMS 4-star. We're in US News and World Report, Newsweek, and we're an age-friendly designated health system. But the reason why I mention these things is if we were to align them and put them side by side, many of the initial statistics that we look at are not dissimilar when you're looking at trying to become the best you can in terms of healthcare. We're located on the North Shore of Long Island, which is an extremely populated area. We have over 3 million people that we serve on Long Island. But given the nature of some of the destination programs we have people that come from all over the country for our acute rehabilitation services, particularly within Parkinson's specialty. If we go to the next slide, one of the things that we look at constantly is the community at large. We have many things that we focus on in meeting the standard of care for the community. When we're doing our strategic plan, we have really 5 pillars of areas, and those are outlined as destination centers of surgery, emergency room, ambulatory growth, acute rehab. But I want to focus a little bit today on our age-friendly initiative, because I think it's a brilliant example of why data is so important and understanding the needs of the community. It's fascinating. If we look at Glen Cove, which is Glen Cove, Locust Valley, if you've ever read the book, The Great Gatsby, it's the Gold Coast of Long Island. But we have a community that serves both the haves and the have-nots. Like any community, it's brought with that. But the thing that makes it so unique is the number of elderly patients that we serve. Caring for the aging is probably one of the most difficult and probably one of the most still not as understood populations. And it's not something that is as, sexy to look at as, some of the areas in cardiology or transplant. But it is probably the group that is represented the most in our hospital beds. And it is the group that our CEO has us really wanting to focus on and do better in terms of our care. And in doing so, it can help us look at the care of all age populations. So if we look at age friendly, actually 17% of all assisted livings in Nassau County exist in Glen Cove. Over 6% of skilled nursing facilities exist at Glen Cove. So if we really look about that, 25% of post-acute services that involve admission are within the elderly for Glen Cove. So for us, aging is probably one of the most important things that we look at. We wanted to look at specifically being an IHI designated organization for age-friendly. We wanted to look at implementing niche, which we know nursing improvement care for the hospital elderly is one of the best models in terms of caring for with our nursing assistants and our nurses married with our physicians. So for us, it was really about building a model that incorporated the hospital, but in the transition of care to the ambulatory practice, to our center or senior center within our community, to our geriatricians, and then to our caregiver center for the caregivers that care for the patients. So we started to look at these areas. And if we go to the next slide, one of the things that we try to do, if we zone in a little bit on this, is this is an example of two of the areas that I showed before. It's looking at the emergency department and it's looking at age-friendly. And these are methodologies to reach a new level of care at Glen Cove Hospital. And we try to look at prioritization action matrix. So within our organization, as an executive team, how do we look at the things that we can do to improve care and then measure how is it working? Is it not working? Quality is probably one of the most foundational aspects of really, I think, operations in a building. I mean, from day one, I always learned that from you and from Andrea. If we look at regulatory, it's not looking at it as a regulatory agency. If we look at CMS, if we look at Joint Commission, we look at Magnet, these are all things that really are foundational managerial models of care. And the concept is doing right by the patient. So it's implementing education, but education alone, we know, is not something that is going to be a high impact necessarily always. It's easier to do, but some of the things that we think are higher impact is community linkages. It is geriatric and palliative ambulatory practices. It's maintaining the age-friendly IHI designations, looking at the 4Ms. So the interdisciplinary rounds that we do, and we hear a lot about interdisciplinary rounds, but it's not about looking at them as discharge rounds. It's looking at them as care rounds. So the 4Ms that we decided initially we were going to look at one unit, making that an age-friendly unit. And we decided that that was not the way to go. That when we looked at our age population, similar to Florence Nightingale, we had elderly patients on every specialty in our hospital. So we decided to implement the 4Ms in all of our rounds as a team, which stand for medication with a clinical pharmacist, mentation, and the primary care nurse is presenting initially first the care of the patient. It's mobility. We have physical therapists there, but our nursing assistants are just as important, and our nurses in mobility of our patients. Patients need to be out of bed every day in the morning. And how can we do that if we don't supply the right environment, which goes back to what Nightingale said, building a hospital, having the right chairs, having the right environment to move a patient and get patients up. And the last is what matters most to the patient, because we may think that what matters most is getting the patient home well. But that may not be the thing that matters most to the patient. It may be being part of their granddaughter's communion. So maybe that's something we can do through our ability with technology to be able to do that. So what we found is, honestly, doing interdisciplinary rounds that way wasn't just giving us better outcome, because we established actually an age-friendly PICG that's tracking those data points, but it was giving us more joy in the work environment. So we actually saw a corresponding improvement in the enjoyment scale and the employee engagement of our staff. So if we go to the next slide.
Before that, if you
Sure.
don't mind, really interesting. I'd like to make a comment because during COVID, the mortality that took place is among the elderly, disproportionately.
Tremendous.
And in New York State, our governor was criticized for the data, nursing home, et cetera, et cetera. So it's really amazing that you were able to focus on this high-risk population, problem-prone population, in terms of the COVID, and try to correct it. So to the age-friendly process, you were able to create an environment in which they are safe and also protected from not only from the situation, but also from the condition. In other words, the cleanliness, the airflow, as Nightingale asked us to do many years ago.
Exactly. It's an excellent point. I mean, I think COVID, in this institution, we opened four units additional that were not there. And, given the fact that we also were blessed to be part of a large health system that is very strong in emergency preparedness, that was definitely a help. We also became a decanting for our other hospitals. I mean, Andrea is in our largest quaternary flagship medical center, and we actually opened an acute ventilatory respiratory unit that took patients from the ICUs. And we did that because of our acute rehab program. We know that if we marry phenomenal pulmonary medicine and nursing care with speech therapy and respiratory management, we saw that 83% of our patients that went into our AVRU actually went home, which is striking.
Yes.
And these were patients that were very ill with COVID over 5-6 month period. So it was something that for us, even though we were opening units that weren't there and redoing areas that had been closed over years, it was a time to constantly stay focused on our strategic initiatives still too, because you're always going to have, COVID was something unlike anything else. It reminded me of the AIDS epidemic when I was a young nurse. And we were trying to learn to care for pneumocystic pneumonia. But we learned that some of the most simple interventions mattered most. Positioning, out of bed. And we learned that from COVID, proning teams. But you mentioned about the concept of Florence Nightingale. When we build new environments, we're in the midst right now of opening a brand new $11 million unit in October. The thing that costs more to renovate a unit but means the most, you mentioned airflow, HVAC systems, having things that have the ability to have appropriate airflows. These things matter. They matter to the comfort of the patient, but they matter to the wellness of the patient and the staff. So I think it's extremely striking and very important. If we look at also where this leads, is we were very fortunate that one of our congressmen, Congressman Tom Suozzi, who used to actually be the mayor of Glen Cove, he's a U.S. congressman.
Mhm.
He felt extremely passionate about the care of the elderly, and he worked with our chairperson, Dr. Maria Carney, who is absolutely brilliant, is our system.
Gerontology.
Exactly. And, we took this whole framework of community involvement in the age-friendly initiative, and we're trying to expand it beyond. So if we look at the inpatient, first and foremost, before the inpatient comes our emergency department. And that the emergency department became a level 1 geriatric, designated by the American College of Emergency Physicians. Why is that important? Not because it's the only one in the state. It's because it's a commitment by the organization to raise the level of care for the care of the elderly. The environmental changes within the emergency department, making non-skid floors, making ambient lighting, making lighting that is rooms to outside so patients don't become disoriented. I think Florence Nightingale would be proud that those are the things some of the things we looked at. And making the staff have better education and understanding of the care of the elderly.
I would like to make one comment. What is very interesting is that Northwell was willing to invest $11 million based on your statistical information.
Yes, yes.
And this shows that there is a correlation between quality improvement data and policy change.
Agreed.
Within the organization.
Agreed.
So, bravo. Thank you.
Thank you. And the federal government actually, to that end, was willing to invest within Glen Cove and gave us $2 million in federal appropriation funding that is being instituted as a grant that allows for the collaboration with geriatrics and palliative medicine in the community for clinical care, education, research, advocacy, and devoting those dollars to making an ambulatory environment. And we already made a caregiver center. So I think this is one of the most striking things, is that having a social worker in that caregiver center, having a space that patients' families can come to, and patients community residents coming to the caregiver center to understand what are some of the resources that when we're, discharging a patient, it's really moving them to the next level of care. So, so this were some of the things that we were looking at. If we go to the next slide, this caregiver center is absolutely fabulous. But it also involves the enhancing of the environment for the staff at the same time. I show these engagement scores of the physician and the staff, not to state that it is just enhancing an environment. It is engaging staff. And we've gone from the 74th percentile in employee engagement to the 98th and 95th. And our physician engagement is the highest too, because people feel they're making a difference. And I think that if you don't have exquisite engagement, you won't have fabulous outcomes, but it all is a circle.
It's very interesting because some people will criticize you, say, oh, What is the big deal of having physician engagement? You have a small hospital. How would you
Great
react
point.
to it?
I'd actually say that no matter if you're small or large, you still have the population that you're dealing with and at the end that you're looking at. So if over time I've been dealing with an N of X number of physicians, an X number of employees, and now I see an enhancement, statistically, it's still an improvement. So whether it's just a different sample size. So it's similar to if you're looking at likelihood to recommend scores on a unit. If my sample is 25, yes, it's a small sample size, but if it's my 25, 24, 26 over a period of years each time, it's still a sample size. So I think it is relevant and it's statistically significant. So there's a book called The Patient Comes Second. And I remember when one of our administrators, Chantal Weinhold, who is retired now, she's actually, I shouldn't say she's retired, she's an incredible coach for executives. When she gave us that book to read, I remember thinking, oh my goodness, that's, patient comes second. But the concepts were so true. You have to teach your staff with respect and listen to them and give them the things that they need. Now, we can't always give everything, but we have to understand what is it that they're looking at that they need to enhance and improve care. And if they feel heard, and if they feel that you're transparent and you're honest, we can enhance care. So let's just go to the next slide there. I think Andrea is going to speak a lot about CMS methodology. And I would say the same things. I'm not going to go into the specifics of it, but I'm going to state that as a 4-star hospital, we've been 4 stars 2 times in a row. We enhanced from where we were as a 2-star hospital. So the sustainability is there. We're not happy being a 4-star hospital. We want to be a 5-star hospital. It's not about the article in the New York Times being a 5-star hospital. It's about the concept that the stars actually relate to true outcome in care. And again, I would state that I don't think we can get there unless our staff are fully engaged to understand why we need to get there in terms of the relevance of it. So that's just a little bit of like an example of bringing data to life.
It's very powerful because Glencore was for a long time a 1-star and a 2-star hospital. And everything changed since you came, basically.
Thank you.
So this is really amazing. Maybe somebody in the audience would like to know what is maybe the 1 or 2 points you can give the audience. What changed? I mean, to move from a 2 to a 4 is very hard. Like anything else in statistics, to make it a decimal point of movement, the process is like huge and very costly. But here you are, you did it.
I think one is leadership. I think that you have to have exquisite leadership that truly understands that methodology. You would always educate, and you continue to educate, educating in the medical school, educating in the finance school. I'm educating in the nursing school for Northwell and Hofstra. It is truly about our leadership and putting into place a structure that you are constantly looking at the data, that you know your numbers. And it's kind of the simplest analogy I can give is Weight Watchers. If I keep trying, but I'm failing miserably on that one. But if you are looking at a goal and you get on the scale and things don't move, even after you've put into processes into place, something's wrong. So for us, it was really about looking at the data, looking at the analysis that planning had done, looking at the analysis of what was already existing in the institution that was strong, and then partnering a true collaboration and respect with our chief medical officer, our chief nursing officer, our chief quality officer, and the entire team and leadership. In fact, they renamed that. We went from monthly to weekly meetings, and it's their meeting. And the meeting occurs whether I'm there or not. And the title they named it was Partners in Progress, which I thought made a statement, a flag in the ground, that from that day forward, we were going to put things into place to improve. So we created a strategic plan, kept feeding the information back to the team, reported the information up to our governing body, which is our medical board through our PICG. And I think trying to constantly enhance and improve and utilizing the science behind it to make things better. We're not there yet. We're getting there. And interestingly, the hospital has also gone to where we're not in the red anymore. We're actually, for the first time, probably in about 12 years, in the black. So what's interesting is if you do things right for the right reason, with quality and performance improvement and data, you will have the right outcomes and you can make money to reinvest within the institution.
In other words, the value of quality created a good economy.
Completely. You said it much more eloquently than I could say. That's a great way.
Dan, if you go to the next slide, as you both said, it's really
Yeah.
about understanding the data. It can even make it larger. And I think that's what we try to do, but I agree that you need to create a structure, process, and go for the outcome. For us, it's about the model of care. We use the interdisciplinary rounds to make sure we're providing evidence-based care. Our order sets are matching. Our clinical practice guidelines reflect the disease conditions that we want to achieve this. We're focused on our community. What do they want? What is their experience like if they have a particular condition? So we also are able to take the frontline input into the initiatives and measures what's important. So in our care model dashboard, what we've done is taken what's important for them to know as in-hospital throughput or meeting the evidence of care. Let's say it's discharge before 2 or length of stay for them or readmission rate. We tie it back on the right side to the CMS STAR measures. And then they know that's a national competition. All of us on the call are probably like, we want that 5-star. We're not there yet, but we got to keep going with the right leaders and getting the input from the front line and understanding the why, as you said. And that, then they'll be happy when you get to the next slide, when you're in the paper and you made the list. And when you celebrate that and in recognition, you reinvent your own success because you have the pride of we move, and it's a patient behind the movement that we did it for. So really proud of that.
So you also see the value, the analytics and the process of quality led you to this type of scores, which of course leads to a good economy for your organization, because both of the organizations, North Shore University Hospital and Glen Cove, are in the black. So this is amazing.
Right, and we put reputation as one of our strategies that we want to continue to improve.
Yeah.
So, and our employees understand that and know what's behind that.
Would you like to make a comment on the last slide, which is the quality for tomorrow?
I recently attended the American Hospital Association session on what quality should be like in the future, and they hosted that with the CDC. And they were really thinking about, like, what do we have to do to get out of COVID and make that more normalized? And what I think I see is really the people drive the process. And working in teams, being inclusive and diverse, having triads and dyads, the nurse and the doctor, with the right team coming in, whether it's for the age-specific competence, where PT is part of it, or the pharmacist, that they are really driving the change. But we have to give them the right education and training for their role that they have with the expectations. This way, we're not duplicating things we do at the bedside, but it's clear to other people that are working together that this is my role as the RN and this is your role as the advanced care provider. I think we also have to continue, as I said earlier, looking at the model of care. How does it have to change? Listening to Kerri, I want to go back and say I need age-friendly hospital-wide. We have it on a couple of units, but how do we incorporate that into the model of care with the thinking and the evidence? And then what I see as a quality leader is we have to teach our own teams in quality about the quality management principles. It's so quick to move from one root cause to the next root cause or worry about the throughput in the hospital. But if we don't give them the basics, as you refreshed us today, Yosef, they're not going to understand the real why and how we can change policy and really take care of the community. And, you know, define what is that high reliable organization we strive to be? And how do we get the employees more sensitive to the safety issues we are facing today, whether that's infection or medication error, whatever. It's really making them sensitive to what matters. And then lastly, it's giving the leaders the right training. And I'm really thankful that the American College of Medical Quality offers this training for our peers in the country. So that'd be my concluding remarks. I think it was really delightful to be with you, our retired Chief Quality Officer and now trustee and educator. My colleague, who now is the Executive Director of a wonderful community hospital, really showing how we could learn from the past and plan for the future and have a better strategy in quality. So I'm pleased. Any closing remarks?
No, I think you summarized it absolutely beautiful. And we're looking forward to the next webinar.